Hello, and welcome to this webinar, Professional Cementation Made It Easy. My name is Dr. Tatjana Repetto-Bauer-Kage, and I will discuss this topic with you in the next 1.5 hours. Ivoclar Vivadent is a family-owned company since 1923. It is located in the Principality of Liechtenstein between Switzerland and Austria. It is located in the heart of Europe. We create this academy especially for you to give you an opportunity to update your knowledge on our latest product. The topic about cementation is very important for our daily work. It will be a quite different webinar because it will be interactive. What does it mean? You will be requested at some parts just to click anonymously some answers. I will tell you when. Allow me to introduce myself briefly. I'm a dentist from Peru, and I have been conducting clinical training in our international training center called International Center for Dental Education for more than 16 years. I also treat patients in our internal clinic of Research and Development department. In addition, I'm a certified health manager and conduct international trainings courses. I want to start with my webinar, which will take around 90 minutes, and afterwards we will have enough time to answer all your questions. Regarding this complicated topic, it is important to get lightening in this labyrinth. Let's go through it together. The content of this presentation contains 3 topics. First, I want to speak with you with which kind of restorations are we dealing for cementation. It could be lithium disilicate or zirconia or other. Then, secondly, which pre-treatment do we do when? Is the pre-treatment of my restoration always the same? And finally, which luting protocols are we following when? So then let's start with the first chapter, with which different types of restorations are we dealing. First of all, let's start with our first survey. Can you tell me, please, which kind of cementation do you prefer? I will just open. So now you will see it. It could be conventional cementation like zinc phosphate or glass ionomer. It could be self-adhesive cementation or adhesive cementation. Remember, your answers are anonymous and just have to click submit, and then I will get your answer. So I will give you a few seconds. And you will see now the results. You see 24% of the participants today works with conventional cementation. That means you're working a lot with zinc phosphate and glass ionomer. So it's 1/4 of the attendees. Then 34% are working with self-adhesive cementation. So that means that 1/3 of you are really keen to work fast and with simple protocols. And 41% of you are working with adhesive cementation. That means that you want to have really high bond strength with a high aesthetic result, maybe. So this is very interesting for me because I can know you a little bit better. But now let's start with our digression to know what is cementation. In the dictionary, you will find the definition that cementation is the binding together of two objects or other things by a cement. In dentistry, we have the fixation of prosthetics restorations like inlays, onlays, partial crowns, and bridges. And this is towards a natural tooth or an implant abutment. So we have different structures here. But which type of cementation do we have? Depending on the preparation, we can say that we have 2 big groups. The first group, for conventional or self-adhesive cementation, we need a mechanical retention. That means that we need parallel walls so that with the friction, our restoration will stay in place. The second group, an adhesive cementation, relies on the chemical bond between the restoration and the tooth structure. Therefore, you should know which kind of cementation you want to use before you start to drill. Now, let's see the importance of the knowledge we should have about our restoration. In general, we can say that we have also here two big groups. The first group is with metal or metal ceramic restoration, where the metal part will have contact with the tooth structure and the cement. Then we have the second group with the all ceramics restoration, where we rely on the micromechanical retention and the chemical bonding with our cement. So we will start very shortly to speak about the bonding towards the metal and metal ceramic restoration. Which kind of cementation we can do in this kind of restoration. So if we do a retentive preparation, it means with a taper preparation between 4 and 8 degrees, we are creating a mechanical retention. This kind of preparation we required for conventional and self-adhesive cementation. If we do minimal invasive preparation where we taper above these 8 degrees, there is no mechanical retention. This kind of preparation we required for an adhesive cementation. So if we want to do an overview about the different protocols, we can resume it like here. For a conventional or self-adhesive cementation, we will need first to sandblast the inner part of our restoration. And afterwards, we can cement it with a conventional cement like our ivoclar cem or materials like self-adhesive luting cements like SpeedCem Plus. For an adhesive cementation, we start with a lab sandblasting the inner part of our restoration. Then afterwards, we apply a primer like our Monobond Plus, and then we apply the adhesive on the tooth structure and the cement on the restoration side. For a metal or metal ceramic restoration, we recommend like multi-link outer mix, and then or our self-curing with a self-curing adhesive multi-link primer A and B on the tooth. And remember that multi-link outer mix is always a closed system, so you only can use the multi-link primer A and B with the multi-link outer mix. So and this is an adhesive cementation for metal or metal ceramic restoration. If we want to continue here towards the all ceramic, this is not so simple as we spoke in the previous slide. So which kind of cementation options do we have for all ceramic restorations? In the dental industry, we deal with two major types of cementation, conventional and adhesive as mentioned. So for the conventional cementation, we will have a gap between the tooth and the restoration, and ideally we will have it with parallel preparation so we get a higher friction. So the retention is also influenced by the gap. So less gap, you will get more retention. Another important factor is the roughness of the surface. The main mechanical retention is done via friction. On the other hand, we have the adhesive luting protocol. Additionally to the micromechanical retention, we are using also chemical bond. Some example of products could be for conventional cementation like glass ionomer cements or ivoclar cem, or zinc phosphate or polycarboxylate cements. On the adhesive cementation, we have products like the Virolink Aesthetic, Nexus 3, or Panavia F. And since a few years, we have also something in between called Speed 7 Plus or the self-adhesive cements. The main difference between the conventional self-adhesive and adhesive luting protocols are that we need a separate bonding agent or primer for the adhesive luting protocol. On the other hand, conventional and self-adhesive protocol don't need a separate bonding. The self-adhesive cement contains an agent which is called MDP, which will create a chemical bond towards the tooth and towards the restoration surface. Therefore, it is easier to apply. Regarding to the adhesion to the tooth, it is increasing from the left towards the right. And it is obvious because we have here an additional agent on the tooth structure, the adhesives. And at the same time, the physical properties are getting better. So you will have higher bond strength also with an adhesive cementation. Which other considerations should we keep on mind? Of course, one of the consideration is about working on a dry working field. But does it mean necessary to use rubber dam? Ideally, yes, but relative isolation is also good. If we take care not to contaminate our working area, I will show you some studies, a continuation. Another consideration is our preparation line. We want to avoid deep subgingival preparation because this is related to a lot of bleeding. And no matter which type of cementation you will choose, blood is always counterproductive. And look here, there are numerous of studies comparing the use of rubber dam with the use of cotton roll, with a reference of the longevity of the restoration. It is very difficult to find any differences. Most of the studies do not show any different, and even after 10 years, there is no difference between the forms of the isolation, the longevity of this restoration. There are a few studies that show the opposite. In summary, all studies conclude that it's more important to make an adequate isolation, but not the isolation method. The method of isolation is not the primary issue. Here we see a study published in 2017, and they see a lower failure rate for the use of rubber dam in case of direct restoration, but the evidence was very low quality. They themselves conclude that in the last line that it is more better quality research is required to see if there are significant difference in a long term. That's good news. It gives us the freedom to choose the type of isolation we want to use. Professor Kamen, a professor from Germany, is asked if it's always necessary to use a rubber dam. And he answered that the use of rubber dam is not necessarily equivalent to good dentistry. But it's much easier to practice good dentistry under the condition of total isolation. This really sums up precisely, and I may as well rectify it. Another aspect is that if you use nowadays a universal adhesive system on the tooth, it needs to be highly technique tolerant. What does it mean? Technique tolerance is a key feature of universal adhesives. It means that no matter who is working on the dentin, with a over super wet dentin, on a wet dentin, a moist dentin, a blood dry dentin, a dry dentin, or super dry dentin, we always will achieve high bond strength. And this is especially important on edge dentin, there where we required high tolerance regarding the degree of surface moisture. Overwetting or over drying are critical steps on the dentin preparation. I will show you a continuation or study regarding the shear bond strength. And here you can see that they have used different kind of universal adhesives, and the aim of this study was to evaluate the shear bond strength of the universal bonding agents on moist, it means blood dry dentin, on dry, so they dry it for 5 seconds, and on desiccated, they dry it for 10 seconds after acid etching, respectively. And they conclude that the adhesive universal show the highest mean value, no matter which kind of treatment you use, and also that others are more sensitive. So those here, you are not allowed to over dry. They need some moisture. And this is important for us as a dentist to know about it if we're working with all the other adhesives. Important also is the cementation affects the durability of the restoration. If the restoration is not glued properly, we can expect debondings or cracks in the restorations. And this finally can lead to failure of our luting procedure. And I think nobody of us wants that our patient will come back with a restoration in their hands. Here you see two types of monolithic restorations. On the upper side, we have Vitamark 2, and on the lower side, we have IPS Emax CAD restorations, our lithium disilicate glass ceramics. On the left-hand side, we cemented conventionally. On the right-hand side, we cemented adhesively. There is a test where you measure the fracture toughness of a restoration material, and this test is to increase the loading until the crown will crack. So here you can see that the feldspathic crown luted conventionally will have a load about 600 Newton. If you're using the same crown but adhesively, you need double forces. For strong material like lithium disilicate, it's not possible to damage the crown as easy. So you need very high amount of forces. And on adhesively luting material, you need even higher forces. So therefore, some materials are not suitable for conventional procedures. Depending on the restorative materials, you have to use an adhesive cementation. So which metal-free materials do we have in the market? And we have a bunch of materials. So we have like here the silicate glass ceramics, where we have feldspar and lucite reinforced glass ceramic. And we have hybrid ceramics, we have composite, we have lithium glass ceramics and oxide ceramics. So, and they have, you see here also, this is the SEM, and they have different flexile strengths. You see it here on this blue line. If you have a stronger material, then you can do also longer span on bridges, like 3-unit bridges for the posterior cases. But the differences are that with lithium disilicates, it's indicated until the second premolar. And for the oxide ceramic, it could be even until the last molar. So which additional parameter helps us to decide the correct cementation type we should use? Unfortunately, flexure strength itself doesn't help us so much. So there's another parameter called fracture toughness. And this is the ability of the material to resist crack propagation. According to the ISO standards, to use conventional cements, the fracture toughness should be at least 2. That means that if a ceramic material has a fracture toughness of 2 or higher, then you can use this material for crowns and bridges for conventional cement. Coming back to my previous slide, which of all these materials can be cemented conventionally? Do you know it by heart? There are not so many. You see only 2 materials has a higher fracture toughness than 2. You see here our zirconia and lithium disilicate. And the lithium disilicate, which have double bonding on the silicates, therefore the di. And here the competitors materials like Celtra or Vita Suprinity, they have just one bonded silicate. So therefore it is lithium metasilicate. And it is a difference. Therefore, they are not indicated for conventional cementation, but our products, they are. Otherwise, you can say it also much more easier. You can say that for IPS Emax Press or CAD or our oxide ceramics, you can use any kind of cementation. For all the other materials existing on the market, you always need adhesive cementation. Let's finalize this chapter with a study which supports the theory that adhesive cementation strengthens weak ceramics, while any form of cementation strategy can be used for stronger ceramics. This is very nice to look for. To sum up the first chapter, let's put some light on the following points. For the conventional cementation, you need to fulfill 3 criteria. First, you need to have a retentive preparation designed. Then you need to have a tight fit. Why? Because less space creates better retention. Then, depending on the fracture toughness, if it's higher than 2, then you can use whatever kind of materials. But you should know these physical properties of the material your dental technician is working with. And this is important also in the communication with your dental technician. For all the other cases, we recommend to use an adhesive cementation protocol. And here it doesn't depend on the design, the fit is not so critical, and it works with all kinds of restorations. Now let's see on the second chapter about our pre-treatment. So let's speak about our pre-treatment option. This is also like a labyrinth. No matter which type of restoration we are treating, we need to roughen the surface or to increase the inner micromechanical retention. And we need also to increase the chemical bond. In the case of the metal and metal ceramic restoration, we will have, as I explained you already, the friction. And for the fancy all ceramics restoration, we will need micromechanical retention plus a chemical bonding. For the roughening, we have two main procedures: sandblasting and etching with hydrofluoric acid. Sandblasting is done basically in the lab for metal and metal ceramics restoration or oxide ceramics like zirconia. And for the glass ceramics or lithium disilicate, we use hydrofluoric acid. But depending on the type of glass ceramics, we need to etch differently long. Many of us are not aware of this important point. Let's speak about glass ceramics. Here we see that we have two different groups. Both contains a glass phase and a crystal phase. One group, where we have feldspathic glass ceramics, they have higher amount of the glass phase. And here we need to etch with hydrofluoric acid for 60 seconds. The second group, which is lithium disilicate, you see that here we need just to etch 20 seconds because we have higher crystal phase. Since feldspathic and lucite reinforced glass ceramic has a bigger glass phase, we need to etch longer than lithium disilicate glass ceramics with lower glass phase. The longer we etch, the more we expose the crystals. When the crystals are exposed, the resin cements are able to infiltrate the gaps and to create any kind of retention. Important is not to over-etch, because otherwise you will overexpose the crystal phase and you will change the physical properties. And this is crucial, especially for veneers, because the ceramic can turn opaque. And another way how to pre-treat our all ceramic restoration is for the alumina or zirconia restorations. Here we always need to sandblast. Mostly is maximum with 1 bar and with particle size from aluminum oxide between 25 and 17 microns. The chemical bonding is done on the glass ceramic with a silane. And this is the bonding on the glass phase. On the oxide ceramics, we have no glass phase, so we need a primer which contains the 10-MDP. The MDP stands for 10-methacrylate oxydecyl dihydrogen phosphates. The first group, the feldspathic or lucite reinforced glass ceramics, has higher glass phase content, and the second group of lithium disilicate have higher content of crystal phase. This ratio between glass phase and crystal phase are different, and that's why we have also different translucencies. It is higher translucent on the left and lower translucence towards the right. The same differs on the flexural strength. You will have higher flexural strength on the right and lower flexural strength on the left. The third group of the oxide ceramics only contains the crystal phase. This makes the material very strong, but at the same time, they are not so translucent and they're not so aesthetic. So regarding the all ceramic indication, we can sum up that due to the low flexural strength of 185 megapascal of IPS Empress CAD or IPS Empress Aesthetic, that we they are indicated only for single restorations. At the other hand, we have lithium disilicate, like our IPS Emax CAT or IPS Emax Press, with a flexure strength higher than 470 megapascal. And they are indicated together with our zirconia material, which are higher than 850 megapascal for single restoration and bridges. The difference is only that here the lithium disilicates are indicated until the second premolar, and our zirconia material are indicated for the complete jaw. There are so many materials, so many different primers, many different instructions and times to remember. Do they need refrigeration, or can I just put it in my drawer? Do you know by heart all these details? To make your life easier, we create one universal primer. For adhesive cementation, I personally preferred Monobond Plus in the past. Monobond Plus is a universal primer which can be stored at room temperature. And it is indicated for glass ceramics, oxide ceramics, metal alloys, and composite. It contains 3 active methacrylic groups. The silane methacrylates, which will react with the glass ceramics, the 10-MDP, which will react with zirconium oxide and with the base metal material, and the sulfide methacrylate, which will react with precious metal. To say it in another way, oxide ceramic and metal alloys always need to be sandblasted. Glass ceramics, they will etch with hydrofluoric acid, and depending on the glass ceramic, this could be 60 or 20 seconds. And finally, afterwards, we can apply Monobond Plus, always for 60 seconds. We wait the 60 seconds, and then we just disperse it with air. So it is a short, standardized process. So now let's come to our second survey. I want to know from you, and I will start the survey very shortly. Okay, I want to know from you if we should sandblast glass ceramic. You can answer 1, yes, or 2, no. So I will close it now in a few seconds. And yeah, this looks pretty good. And let's see what your answer were. So 25% of you are responding that yes, we can sandblast it. And of course, there are some protocols on the markets that they say you can sandblast glass ceramics, but let's speak about this later. And 75% of you, so the majority, say no, we should not sandblast. I am personally with the 75% of you, and I will tell you why. As I told you, it exists, of course, protocols, but I prefer not to sandblast glass ceramic, and I want to explain you why. So let's see to some studies, and they say that sandblasting is not suitable for glass ceramics, otherwise you will weaken the glass ceramics. With the sandblasting on ceramics, you will leave like micro cracks, and these micro cracks can propagate within the time, and it could end up with a fracture. So at the end, you will lose the restoration. And even more important is that with sandblasting of glass ceramic, you will not improve the bond strength. So maybe you will think, oh, with sandblasting, I will have higher bond strength. This is not like this. Look at the results of this study. So if you sandblast and polish, you will have 31 megapascal. So it's 2 more megapascal than the control group where you do not anything. And if you etch with hydrofluoric acid on a polished surface, like we recommend, you will have a significant growth of 15 megapascal on the bond strength. Therefore, sandblasting of ceramic is not having advantages. Maybe it's having big disadvantages in regards on the bond strength. And the conclusion of this study is that hydrofluoric acid provides the highest bond strength. But we all know that hydrofluoric acid is toxic and dangerous. Is there any other possibility to pre-treat glass ceramic effectively? The answer is yes. Nowadays, I prefer to use monobond etch and prime for glass ceramics. It is etching and priming in one easy step. And you have just one bottle with one application protocol. The following video shows you the pre-treatment of glass ceramics. So clinically, after the try-in, we will rinse the restoration and we apply monobond etch and prime for 20 seconds. We just have to scrub it in and then we leave it for reaction for 40 seconds. It is crucial to wait the time. Afterwards, we rinse with water and then we dry for 10 seconds. So then we will add our cement like viral aesthetic, and then we will follow their instructions for use. So monobond etch and prime has less aggressive etching as hydrofluoric acid. Despite it contains HF ions in this formulation, it is not releasing hydrofluoric acid in water solution. This is ammonium polyfluoride. And it is less toxic than hydrofluoric acid, and additionally, it contains as a second component silane. Monobond etch and prime is suitable for conditioning of different glass ceramic. The investigations show here, including specimen of several types of glass ceramic, of pure glass ceramic, not the hybrid ones, that it is comparable to the pre-treatment with hydrofluoric acid and monobond plus, even after thermocycling. The higher reaction here on lithium disilicates depends on the interaction with the crystal phase. The stronger the ceramic, the higher the crystal phase. Therefore, the monobond etch and prime has here a higher reaction with the crystal phase of this glass ceramic. In general, you can say monobond etch and prime is very optimized product for the pre-treatment of pure glass ceramic. Compared to hydrofluoric acid, monobond etch and prime condition the ceramic surface much more gently. That means that you will not weaken our glass ceramic. That the pre-treated monobond etch and prime shows lower than 50% roughness on the surface etched with hydrofluoric acid. So therefore, the flexure strength of the glass ceramic is less pronounced, and therefore it is conditioning more gently. Regarding the cleaning process after the try-in, depending on which material you are using for your restoration, the cleaning agent may not interfere with the bond strength, whether it is lithium disilicate or zirconium. If you are using lithium disilicate, you can use, let's say here, phosphoric acid, and it will not interfere regarding the bond strength. This is a good option, but however, if you use it on zirconia, here we will have a problem. Phosphoric acid on zirconia is reduced the bond strength on half of the possibilities, from 52 to 26. This is a concern but there's a reason behind that. So when we want to bond to zirconia, we want to bond to this hydrogen or OH radicals. And phosphoric acid has similar radicals like the MDP. So therefore, they are like competing of the free radicals. I will explain you in this next slides. So here first you see that the surface of oxide zirconia, we have these free radicals, these OH. And with the phosphoric acid methacrylate, this will have a reaction like this. So we will create bonding and liberate water, and therefore we have a good chemical bond strength on this primer. But what happens if I use phosphoric acid as a cleaning agent? So phosphoric acid also has here OHs, and they will react and they will create double bond and they will liberate water. So after rinsing this away, if I want to come with my MDP, let's say here, there will be not a possibility for reaction. So therefore, the chemical bond is decreasing so dramatically. Therefore, not use always the same protocol for glass ceramic and for zirconia. You have to think about which materials you are using, and then we have two different protocols. Now the question would be how we can do a proper cleaning after the try-in, especially for zirconia restorations. There is a suspension from ivoclar Vivadent called ivoclean. The working principle of this material is quite simple. After the try-in, normally we have a contamination of saliva in the inner part of the restoration. So even if we rinse it away, the saliva contains a high number of proteins, which are affine to the zirconia restoration. Even when we rinse it away, there is a film of proteins which will stick on the zirconia restoration. Ivoclean contains small metal oxide particles in form a sphere, and these particles will absorb any contamination like a sponge, and after 20 seconds we will rinse it, and then everything, our zirconia restoration is clean. And this advantage of ivoclean you can see also on the working zirconia here, that we will have again our high bond strength. So especially some dental technicians are pre-treating the glass ceramic with hydrofluoric acid before in the lab. So if you use it, you can use also here ivoclean for the glass ceramic and then apply Monobond Plus. Or use a Monobond Etch and Prime for glass ceramic and after the trying. So let's see this short video. We have first to shake it because, as I told you, this is the only suspension ivoclar Vivadent has in their portfolio. And then you just put one drop on a pad. This is our Viva pad. And then with a brush, you will apply it in the inner part of your restoration for 20 seconds. And you see, with a brush, you take it, you just be sure that you move it well. This case is a veneer. We have it with an Optra stick, and then my colleague just apply it on the inner surface for 20 seconds. Afterwards, he rinse it off, and then he dry it. So this was a quite simple but important step for zirconia restoration, especially. So this is an external study which shows that ivoclean group shows similar or better bond strength than with the other groups. And I want to show you afterwards also some very interesting SEM. Here we are, where you see that here we have hydrofluoric acid on ceramics that will increase the surface. And this one done, the upper part pictures are done on zirconia, sandblasting, and here we have sandblasting on metal. But please be aware that the pressure during sandblasting is also important, because if we use too high pressure, this could lead to a large volume expansion, and this alters the coefficient of thermal expansion of the surface of zirconia. You know that for zirconia we have these three phases, where we have the stable form, which is called the monoclinic phase. Then we have the strong form, the tetragonal phase, and finally the translucent or cubic phase. The last part is the weakest, and with too strong sandblasting, we can move between the phases of zirconia, and this will make a change from the tetragonal phase to the monoclinic phase, and this will lead to expansion. And this expansion can lead to a poorer bond strength because the fitting is also not good. Therefore, we have higher risk of failure. The study of a group of friends, they released a paper for a compendium of continuing education in dentistry. They looked after pre-treated dental tissue with sandblasting. And a lot of colleagues are using sandblasting for enamel and dentin. The upper pictures are showing you the enamel, the sandblasting on enamel and on dentin, and the lower picture is after, sorry, the upper picture are with phosphoric acid, the lower picture after sandblasting. They found that the tooth treated with sandblasting process, it will expose a little bit more of dentin tubules than and create any kind of etching pattern on enamel. However, they still not get etched to be able a good shear bond strength. As you can see here, there was no significant differences between those groups. So please observe that if you only sandblast alone, this will not improve the bond strength. If you want to sandblast, you have to use afterward phosphoric acid. And this is also to get rid from the contamination part. To sum up the second chapter, so here I also want to put some light on the different points. So we have different pre-treatment options. First, for glass ceramic, we have two options. The first option is using hydrofluoric acid, and here depends on the glass phase that you leave the reaction for 60 seconds, like feldspar or lucite reinforced glass ceramic, and 60 seconds for lucite reinforced glass ceramic. And for loose lithium disilicate, we have to etch for 20 seconds. Additionally, we need monobond plus for 60 seconds for silanization. Or the second option is to use monobond etch and prime for the pure glass ceramic, where you have to agitate for 20 seconds, to leave it or rest for 40 seconds, rinse and dry for 10 seconds. On the other hand, we have our oxide ceramics. So you always need to sandblast to activate the surface with a minimum of 1 bar and with particles of aluminium oxide particles between 25 and 70 microns. And if you make a try-in, we recommend to use ivoclar. Important here is always to shake, and then you apply it for 20 seconds. Now, let's speak about our third chapter of luting. Here, the aim is to know which luting protocols are we following when. In the beginning of the webinar, I explained to you the different types of cementation we have nowadays in dentistry. Here I want to concentrate in the adhesive and self-adhesive cementation. So we want we know that the adhesive cementation needs a separate adhesive system. Like if you want to use Viral aesthetic, we recommend as a manufacturer to use our universal adhesive like Adhese Universal. A wide variety of restoration materials are available nowadays due to the different properties and depending on the demand of aesthetics, we have different possibilities. So we have metal-based, which will not transmit any light. Then we have oxide ceramic, which are transmitting very low light. And then we have the glass ceramic, which are very good in transmitting light. So many people doesn't know that on the ceramics we also have different translucencies. And this also makes our choice much more difficult. So let's start with our last survey. I want to know from you the following. Who is responsible for a failure after cementation? Is it because of the restoration material? Is it because of the cement? Is it because of the adhesive system or our polymerization unit? So please just think about it, and what is your opinion? Who is responsible when a failure after cementation happens? The restorative material, the cement, the adhesive system, or the polymerization unit? And then we will see what is coming out. So this is the result. So 11% of you think the problem could be on the restorative material. 23% think the cement is the weakest point. And 48% thinks that the adhesive system could be a part. And 18% think the polymerization unit could be the problem. So thank you first for responding. And it's really interesting because most of less people, in this case, the third place, don't think about that our polymerization unit could be a problem as a failure. And I want to show you some studies which are really interesting in this part. So how much light comes through restoration? So this always depends on the translucency or the opacity of the restorative material. Here they use this Ulbricht sphere, and this is to measure the light intensity from this unit. This is the blue phase style, which has 1,200 milliwatts per centimeter square. And sorry, they used here 3 different translucencies, an HT, an LT, and an HO, so high opaque material. With a high opaque material, you see that they use different thickness, 1, 2, and 3 millimeter thickness of ceramic, and they just put in between of the measurement, and you see also that the thicker the ceramic, the less light pass through it. And you see it also here with the high opacity is really unbelievable. And we start here on the point 1,200, and we know that minimum 400 milliwatts per centimeter square is necessary, so the resin part are able to polymerize by the light curing. You see that for the HO, you always need a dual cure luting cement, otherwise it will not be possible. and we say until 2 millimeters, you can use with high translucent materials for veneers that say light curing cements. But after the 2 millimeters, we always will need a dual cure cement. So it is recommendable to use powerful light curing devices because you saw that up from the first millimeter, you will have a drop of 50 to 80% of the power intensity to reach the cement. Professor Krejci from the University of Geneva always recommended to have at least a curing light from 1000 milliwatts per centimeter square. And now the following question will be about the exposure time. How long should we light cure the restoration? Ivoclar Vivadent recommends a light cure just 10 seconds per millimeter thickness and quarter. As you saw in a previous study, the thickness of the restoration can influence the light transmission. If you have thicker restoration, you have to increase accordingly the curing time. It is not possible to overcure. So if you are not sure, you always are safe with higher time of polymerization. We all know that we have different kind of cements on the market. Which one does you use and why? I have my preferences, and it is because of their physical properties. Let's see some relevant properties for cementation. Let's have a look to this interesting test of stability of dual cure luting composite. All of them are in the same category. I will start the video and please observe the stability of the different materials. In total, the running time was 2 minutes and 50. And what is the clinical relevance of this stability? Who of you have struggled after cementation with the excess in the interdental area? If you're using a material which is too flowable, it will go in between the interdental part. So therefore, I prefer Virolink Aesthetic DC. Here is Virolink Aesthetic LC, and you see that it has less stickiness. So I can wipe it away, and this is important for a veneer, that I can just wipe it away and it will not spread and glue everywhere. So also for the light curing part, this is important to be as short as possible. These are the reasons why I use them. And it is always to use a dual cure bonding system, because you will perform even on the self-cure part as on the dual cure part, of course. And you see here that you can achieve 90% of the maximum strength just with the self-cure mechanism. And this is huge. Let me show this emergency patient I had a few years ago. I treat her with Virolink Aesthetic DC. This was a female patient with diabetes, and after a barbecue, the crown was loose. And it was 40 years in the mouth, and we needed to redo the endo and repair the distal restoration on 2-3. Look also on the gingivitis. So we create IPS Emax CAD, and after crystallization, I just stain and glaze it, and I used the program at CS3 at that time, and you will have this natural staining. Then I try the luting procedure. I always start with a try-in paste, and this is because I want to see the final color to check it, and also that this will replace the cement, so the crown will not move anywhere. Additionally, the patient has a problem of cross-biting, if you see here. Then I prepared with monobond etch and prime. I apply it as I told you, for 20 seconds. I leave it for 40, rinse it, and dry it for 10 seconds. So here I apply it, I left it, I rinsed it, and after I dry it. And then, of course, for the tooth side, I use our medium, sorry for that, it's just moved. I use the medium coarse Proxit fluoride free. Why fluoride free? Because afterwards I wanted to do an adhesive luting protocol, and I don't want it to strengthen the teeth before. So after a selective etching on the enamel, I apply Adhese Universal in a Viva pen for 20 seconds on the tooth. And I love this delivery way because you have no waste. And you have a very low film thickness of 10 microns. And this, because it's a light cure adhesive, needs to be polymerized. And also here, you can see a study from Moritake. In 2018, he suggested that agitated 20 seconds will have very good resin infiltration in the dental tubules, and with the polymerization, you will have a good hybrid layer. And this will, of course, also increase the high bond strength comparing to other universal adhesives. So afterwards, we apply Varolink Aesthetic DC in the inner part of the restoration, and we spread it with a micro brush. Then after seating the crown, we do the pre-polymerization per quadrant. So 2 seconds off, 2 seconds off, 2 seconds off in the different ways. Then I applied liquid strip, our glycerin gel, and I just polymerized through the crown, then the final part, also from occlusal and from mesial. And after rinsing off the liquid strip, I always finalize my procedures with a varnish. And depending on the caries risk of the patient, I use a fluoride-based or a chlorhexidine-based varnish. Remember that this patient had diabetes and bleeding gums. So therefore, I choose a chlorhexidine-based varnish like Cervitec F, because 1 drop is enough for 3 teeth. So I applied it on the margin on the crown, on the margin of this crown, and around this teeth. For more details, you can watch our webinar about varnishes on our demand section. Here you will find the before and after pictures, and you can observe also here the bleeding gums, and this was the reason why I used the Cervitec F. So now coming for the next topic, a lot of colleagues think that self-adhesive and adhesive luting materials are the same. You only skip the adhesive, and that is wrong. We are speaking about a different category of luting materials with a different chemical ingredient. So the main why we do not need an adhesive system on the tooth or a primer in the inner side of the restoration is because the special component called the 10-MDP. This 10-methacryl oxyl decyl dihydrogen phosphate stands for this 10 times 6X here, and the MDP are including as a primer for zirconia, and this is therefore it is reaction with the zirconia surface, and this is the reason why we don't need an additional primer. And the phosphate group will bond towards the zirconia or any metal restoration, aluminum oxide or metal oxide. And if we're working with lithium disilicate, with glass ceramic, then we need a separate pre-treatment for this glass ceramic, like hydrofluoric acid and monobond plus, or the newest monobond etch and prime. We already spoke about it. And at the other hand, the MDP is also reacting chemically with the hydroxyapatite surface. Sorry for that. So most of the materials with the MDP has very good bond strength in this category, especially when it's used on a dual cure mode. But important is also to see the self-cure mode to have high bond strength, because I told you metal and zirconia doesn't transmit the light so good. So now let's see about the bonding between the MDP and the different restorative materials, like you see here on dentin, on zirconia and titanium. And even self-cure mode, you will see we can reach very high bond strengths. So therefore, the self-adhesive cement can be used for strong restorative materials like zirconium oxide, metal, or lithium disilicate glass ceramics. Please remember that here for these, we need a separate pre-treatment with hydrofluoric acid and silane or monobond etch and prime. And but it is faster to work with them together. But now, which luting system should we choose for implant abutments? We recommend a self-adhesive cement for implant abutments because there is no tooth, so no adhesive needs to be applied. Additionally, the MDP will work on the abutment and on the restoration as well. So this is a good solution for implant abutment. So after taking off the excess, there's a general recommendation to use an air blocking gel or glycerin gel on the margins. And this is because the use of resin-based cements to avoid an oxygen inhibition layer. You can see here our air blocker is the liquid strip, and here if you apply it, you will have a complete polymerization of the cement. If you are not applying it, then you will have here a gap around of 265 uncured resin on your margins. So, and this uncured material can lead to stainings and decolorations on your margins, and nobody wants this. Here also using self-curing mode, you see the oxygen inhibition layer is around 200 microns or more depending on the material. If you light cure the material, this thickness will be much lower but still existing. So here you see the oxygen inhibition layer on a SEM. On the left side, we use the air blocker and you see very good polymerization. But here on the right side, we don't have such a good polymerization. And this roughness here may increase plaque accumulation, may increase decoloration, and maybe they're discussing about maybe also secondary caries. So now my question is how we can avoid it. Very simple, using our liquid strip. Because the glycerin gel, it's easy to apply and easy to remove as well, and is water soluble. I would not recommend to use Vaseline because this is very difficult to clean. So here I want to show you very shortly another clinical case I've done with my colleague, Dr. Anton Lebedenko. All the pictures you will see here are before Corona time. I had this male patient with a problems and this gold crown, he said, for more than 30 years in his mouth. But my assistant always, after the cleaning, she said he's always bleeding and always coming and always bleeding pockets. And he has gingival reaction. And if you see the x-rays, we see also that we have started here bone resorption. And we were discussing, and maybe we thought it could be also like an allergical reaction because maybe it's not pure gold in that metal. So we wanted and we choose a biocompatible material like our zirconium oxide. And before starting a treatment, one week prior treatment, my dental assistant, she always do a prophylaxis treatment and polish it with Proxit Pink, and afterwards she applies Cervitec F. Cervitec F contains 1,400 ppm of ammonium fluoride, 0.5% of cetylpyridium chloride, and 0.3% of chlorhexidine. And why she apply it? Because after drying, the concentration is 10 times higher, it is colorless, and the chlorhexidine and cetylene chloride will kill the bacteria. So 1 week later, when we are doing the procedures, we have less or no bleeding. This is really a hallelujah. And additionally, we give to high-risk patient our chlorhexidine-based mouth rinse, and I prefer to use Cervitec liquid because it's not bitter and it contains also a very nice mint taste. In this video, we scan the patients with our trio scanner of 3 shape. You see the opposite tooth and the lower tooth, and you see also that the scanner is scanning everything, the cotton roll, everything you have in the mouth. And you will see here also the picture, the intraoral pictures, and from the scanner. This is the bite. Sorry for that. It just moved. And then we sent the data. At that time, it was not possible to mill it chairside, so I sent to my dental technicians, which is the dental technician master, Roger Zünd, and our dental technician, Gigo Mitrovic. So they create for me an IPS Emax circuit empty multi crown, and they have done it everything virtually. They look at the contact point, the abrasion. Then they use the milling disc, and at that time we had an old milling machine, and then we use this translucent zirconia, and this is after the sintering, and this is after the characterization. So after the stain and glazing, they send it back to us, to Anton and myself. And first we made a try-in. I use the try-in paste of Varolink Aesthetic just to make the occlusal checkup, and then we polish it finally. And then we shake, of course, the ivoclar and apply it in the inner part for 20 seconds. Then we rinse it. And then we prepare, as you see here, the preparation with our retraction cord. I like always to work also here with this, I always say like snake suction to just get away from the tongue. And then we used Proxy medium coarse fluoride free. I already told you why. And afterwards we seed it, and now SpeedSem Plus, we also take away the excess, but the excess has to be taken off just with 1 second pre-polymerization. This is crucial, otherwise you need a burr to take off the excess. You see, it's 1 second off, 1 second off, and you make it per quarter, and then you take a scaler, and afterwards you will see how easy it is to take off the excess. You see it here. And yeah, my assistant is just taking this off. So it's quite easy to work with it. And of course, we have the quarter technique pictures with the liquid strip then afterwards on it. And also here, even if we're using now SpeedSem Plus and we're using zirconia, so the light will not pass through. So I have to wait now for the self-curing reaction. But also for self-curing, we always protect our margins, wait the 3 minutes, then we rinse it off. And this is the before and after. So the after and before, let's see it like this way. And also you see here the X-rays 2 years later, at least we can see that the bone resorption could stop. And the patient has stable also situation for the gum bleeding. Fortunately, he is not bleeding anymore so hard. So let's come now to the summary. Remember, before you start, you should know which kind of cement and ceramic you want to use, because this is important to know which kind of preparation you will do. If it could be retentive, this is ideal for conventional or self-adhesive fluting materials. If you want to work minimal invasive, then you should choose adhesive fluting cementation. And here you will require a separate adhesive system. To sum up the third chapter, let's put some lights here also on the following points. For the luting, we have these different options, which I mentioned before. And I just want also to tell you, we have a special page, the cementation navigation system, and an app, a free app, the Shade Navigation app. I just can recommend it to you because this will improve also the communication with your dental technician. So to make your life easier, we recommend for high aesthetic with veneers or translucent glass ceramic, we recommend to use Virolink aesthetic. If you want to work with zirconia or opaque glass ceramic or even metal, we recommend to use SpeedSem Plus. So here, this is about the cementation navigation homepage we have. Here you can see some small videos explaining you step by step how to use it. And what I like it the best is that you can create your own PDF and just print it out so your dental assistant can make like a check on all the steps. And this gives you also the security on your records that you didn't miss any step. And it is your auto control. And for before treating the patient, you have the opportunity to see these very nice animated videos. For the Emacs Shade Navigation app, if you are not sure about the translucency, you can use this app. And it is available for Google Play and App Stores. And important is that you as a dentist also need a natural dye material shade guide. This shade guide gives you the tooth color of the prepared dentin. So normally we are used to check only the final color, but it is also important to know about the dye, which color is the dye to choose the correct translucency of your ceramics. And this you will find here in these 5 steps. So with that say, I hope I can show you how professional cementation made it easy is possible. And here again, the names of the homepage and about the app. And you can find also more details for further webinars on our Academy homepage. The link is here on the title. And with this, I want to thank you for your kind attention, and I want to thank you for your participation on our reviews. See you the next time on the next webinar. Thank you for joining me. Bye.